I'd like to welcome everyone. Thank you for this opportunity. Today we're going to touch on a topic that's received a lot of interest lately, the anterolateral ligament. And, we're going to discuss, can we make ACL surgery better? My name is Demetris Delos. I'm a sports medicine shoulder and knee surgeon with the ONS group. So briefly, we'll touch upon the basics of knee anatomy. We'll go over the ACL in more detail, and we'll go over ACL surgery and some of the things we need to consider. We'll also touch on the, quote, discovery, unquote, of the anterolateral ligament, as well as anterolateral ligament surgical technique and the outcomes of the surgery. So when we look at the knee, we oftentimes will think of it rather simplistically as a hinge joint, but it's a lot more complicated than that. It's primarily three bones: the femur, which is the thigh bone, the tibia, which is the shin bone, and the patella, which is the kneecap. And you can imagine that if these bones weren't connected to one another in some way, they'd just be floating around in space. But the body has developed ligaments, and they are these strong fibrous bands of collagen that attach one bone to another. And so they're what provides stability and limit excess motion. Now, on either side of the knee, we have what's called the collateral ligaments. The medial collateral ligament is on the inner side of the knee. Sometimes that gets injured with certain sports, especially with skiers, for instance. The lateral collateral ligament is on the outer part of the knee, and that's rarely injured in isolation. Typically, that's injured when there's a substantial trauma to the knee. And then there are two in the middle, which are called the cruciates because they crisscross one another: the anterior cruciate ligament and the posterior cruciate ligament. So we'll obviously really go more in depth on the anterior cruciate ligament. The ACL, of course, everyone's heard of it, is the main structure which limits excessive anterior translation of the tibia relative to the femur. Or you can think of it as restricting the femur from sliding too far back on the tibia when the foot is planted on the ground. Now, we always think of it in terms of front-back motion, but there's also a rotational component because the ACL resists excessive internal rotation of the tibia as well. So it prevents the bones from rotating too much that way. And when you push off on a single leg, say when you're playing a sport like basketball, what you're doing is basically, in essence, you're extending the knee and the femur is starting to slide back on the tibia, but it's also rotating. And it's critical that the ACL is functioning properly when you push off that leg or when you land, say, from a rebound or from a header. Now, ACL tears are, of course, very common. I'm sure almost everyone has seen or heard of someone who has had an ACL tear, and the numbers seem to indicate that it's probably over 100,000, maybe over 200,000 per year that occur in the U.S. alone. And a lot of these patients do end up having surgery, especially if they're active and they play certain sports that involve cutting and pivoting. So ACL surgery, the way we think of it nowadays, actually works very well, but there are some things we need to consider. There's a group of patients that are still at high risk for re-injury, even when the ACL surgery is done perfectly. And this includes primarily teenage and college-level males or professional males who participate in collision sports, such as rugby or football, and it goes for young females who also participate in impact and pivoting sports such as soccer and basketball. And ironically, we always think of the young males playing football, for instance, as a very high-risk group, and they are. But the young girls who play soccer and basketball are probably at even higher risk. And the risk of re-tear can be as high as 10%, 15%, maybe even slightly more. The other thing to remember is that we think that obviously a stable knee is much better in terms of preventing arthritis in the future than an unstable knee. But that's still pretty controversial. And so even with ACL surgery, you might be at risk for post-traumatic arthritis. So the question is, are we missing something? Is there something we can do to make ACL surgery better and to prevent re-injury, especially in these very high-risk athletes? Now, surgeons have known for many years, over 100 years, that when you have an ACL tear, oftentimes the outside or the lateral side of the knee also sustains an injury. And we can see this even on a basic x-ray where there's a fleck of bone that pulls off the tibia And this is what we call the Sagun fracture. So clearly, there's not just something going on deep within the knee where the ACL is, there's also something going on towards the outside or the lateral side of the knee. And so to recap, we know that ACL surgery works. We know that it's reliable and it can create reproducible results. The majority of patients will go on to resume their pre-injury activity levels, but there is that small subset of patients who might be at risk for further injury. So how do we improve the results and prevent these poor outcomes? Should we look to the past? And so if we take into consideration what we just discussed with the Sagun fracture and injuries to the lateral side of the knee, we sort of segue into the anterolateral ligament. So there was a European group headed by Claes who did anatomic studies of the lateral side of the knee, and they published their results less than 10 years ago. And it really caused a stir in the orthopedic and musculoskeletal community, primarily because it was touted as perhaps a new ligament, and it was called the anterolateral ligament. Now, this actually has been described before, although admittedly, their studies were very good at better defining the origin and the insertion of this ligamentous band of tissue. And the truth of the matter is, for many years before we developed excellent arthroscopic techniques, orthopedic surgeons were doing primarily extraarticular surgery for the ACL. What does that mean? They were doing things on the side of the knee to control the knee and provide stability before we really understood the function of the ACL and had good ways of dealing with it. So ALL surgery in some ways is a blast from the past, but it's a lot more sophisticated nowadays, and several procedures have been described to reconstruct this ligament on the side of the knee that provides rotational control. And if you look at this cartoon, you'll see that basically what the illustrator has done is shown one of the techniques where we take usually a hamstring graft and we anchor it to the side of the femur by the lateral epicondyle, and then we tunnel it under the skin and anchor it to an area on the lateral side of the tibia. And the goal is to limit excessive internal rotation as well as possibly translation. Now, just to also mention this, ALL surgery is in some ways falling under the category of what's called lateral extraarticular tenodesis procedures. These are types of surgery that typically involve the iliotibial band and taking a portion of the iliotibial band and using that to control rotation. And so that's been described for many, many years, and that's a well-known procedure. The ALL technique that we do nowadays mimics that to some degree. And it's really unclear if the IT band procedure or the ALL reconstruction with a graft, which one is better. It's not really clear yet. Now, when we look at preliminary results of ALL surgery that's done in conjunction with ACL reconstruction surgery, we see that there's possibly improvements in stability as well as reductions in the rate of ACL re-tear. And this also goes for the iliotibial band procedure. So there's a lot of promise when we talk about these surgeries. So who can benefit from ALL surgery? Well, the highest risk patients undergoing ACL surgery for the first time. This typically includes teenage and college level athletes, pros who play football and rugby, as well as soccer and basketball, active individuals undergoing ACL surgery for the second or third time, so people undergoing redo surgery, as well as patients who are really loose jointed. Those are the types of people we might think about doing the ALL surgery for. So in conclusion, we know that conventional ACL surgery, the way we do it now, works, but there is a subset of patients for whom a re-tear is still a possibility. And so addressing the anterolateral ligament of the knee at the time of ACL surgery may be of benefit to those patients. Now, still, there are questions regarding the best technique, outcomes, and whether we're over-tightening the knee, but those are things that we're working on to try and figure out much more clearly. I appreciate your time. Thank you.